quite clearly here we're reviewing a complication as a result of your imaging with the best interest of obtaining a perfect result. But you highlight that, I mean, your regret seems to be the repot prior to passing the IVUS probe down the circumflex. Could you just clarify, you performed a pot inflation of the left main prior to the recross and the repeated IVUS evaluation of the unstented?
Yeah, actually, the sequence of the case was like we stented across from left main to LAD. Then we performed a pot. Then angiographically, it was excellent result. There was no angiographic compromise of the side branch. Then we again took a IVUS pullback from LAD to left main. At that point, we saw some floating struts across the circumflex, and there was some degree of malapposition noted just proximal to the circumflex ostium, that is at the circumflex carina. So our plan was to perform a kissing balloon and perform a report. That was the logical conclusion that was planned. And to select a balloon for the side branch, we tried to pass the IVUS catheter, and then we had that catheter getting caught in that malapost and struts. Probably what we could have done is that in the hindsight, our concern was that the publication of some studies, especially last European Bifurcation Club, there was some OCT follow-up study that showed that if you have a floating struts across the side branch, then that predicts long-term poor outcomes in the side branch outcomes, especially with regard to restenosis. So that was our concern. So what we could have probably done is we could have done a low pressure undersized balloon dilatation, then a report, and then we could have gone ahead and performed an IVUS. That would have been better. In the hindsight, that's what we could have felt, but always that is a hindsight. Yes.
Yeah, hindsight's a wonderful thing, isn't it? Yeah. So the other aspect to this, obviously you highlight that there's significant deformation of the left main component of the stent, which led to you converting into a crush.
Yes.
Did you try to repeat IVUS down the left main LAD wire to see if there was an ability to just re-expand the deformed element?
Yeah, the wire, luckily the wire in the LAD was, we didn't lose that access, but even the smallest balloon that was available with us was not getting across the LM ostium. Smallest available balloon in the shelf was 1.2 millimeters. That could not be passed actually with a lot of efforts. So we had to abort that attempt. Our first choice was to redeploy that stent, which is possibly peeled away from the vessel wall by the tug of the IVUS catheter. But the balloon could not just pass across the left main ostium. So then we had to, our plan B was to come through the space between the stent and the vessel wall into a circumflex and convert it into a decay crush type of stenting strategy.
Okay.
And in the meantime, we had a plan to snare out that IVUS catheter, which is lying from left main to the circumflex ostium, but the snare catheter, that is 2 mm snare, could not get across the left main ostium at all.
You say a poor man's snare, you mean using a balloon and a guide wire within an existing catheter, or?
No, we tried both methods. We tried to pass the conventional snare, that is from the 2 mm snare, and also we tried to catch with the balloon, which is passed distal to the broken catheter, and try to pull it back into the guide, which was there in the proximal left main. But the catheter kept shifting away from the balloon, and then we had to go for exclusion from the lumen as the next plan.
Right, very good. Remo, don't know whether you...
Okay. So just to review the case, so you one pitfall is that sometimes you do this first pot, but with the first pot the entrance in the side branch is minimal. So before entering in a side branch after pot, the first pot, you should open the side branch with something first. So doing the IVUS in the side branch without opening with the balloon is dangerous. It's dangerous because you don't know if you did the proximal cross or the distal cross. You don't know where you are with your wire. If you are abluminal, for example, maybe you are how do you know that you were intraluminally or not intraluminally first? This can happen also when you do repot. It's more frequent with repot. Remember, when you do repot, if you have already implanted your stent, you have already done your kissing balloon inflation, you do the repot, and then you reposition the new carena, and you jail again the side branch. If you go with an IVUS after repot, because you have to put something in the side branch or to visualize, sometimes you can catch. So every time you do a pot or a repot, you can modify the entrance in the side branch. So the best things to do is to enter in the side branch after side branch dilatation or kissing, and then finish the procedure with the proximal pot, but not to go to the carina, because this is very unsafe. I like also the way that you, how were you able to go under, because there was probably when you remove the IVUS catheter, you create an attraction of the guiding catheter and you crash, you create this, you modify completely the stent because you attracted too much the guiding catheter. So this is another maneuver that you have to do with the left hand, just to pull on the guiding catheter to avoid this attraction inside, because you have this complication, which is more frequent that we think about, this longitudinal deformation of the stent that created this problem. So this longitudinal deformation favored the abluminal rewiring, and then you were able to crash the stent. Otherwise, it was not easy to recover the stent.
Yeah, it was very difficult to get behind the stent strut, especially towards the ostium of the left main. The stent was really deformed, so it was not admitting any wire or any hardware. So we had to really struggle to get underneath that stent struts from the left main and get into the circumflex in the first part. Yeah.
Paradoxically, you use the guiding catheter to crash more the stent and to go subintimal. That's one possibility. But actually, in this particular case, under the strut of the stent, you can use the guiding catheter to push the stent away from the side branch and then cross with the guide wire. This is something illogical, but sometimes it's useful.
It works. Yes, it works. Yes. Yeah.
Should we move on to Gregor's case?
Yeah, I saw it, and I have some questions. It was the case of the 001 case that was this second diagonal, and there was this protrusion, and I want to ask. So your plan was to precisely put the stent at the ostium of the second diagonal, or was to protrude inside the LED? What was a mistake, some motion? And then, because what happened later? Because this, aversion was due to another balloon that pushed the stent. You use another balloon in the main vessel, and then you deform the stent that went down. This is first question. And the other observation that I did, because you were unable to open completely the balloon, probably you were not inside the true lumen of the stent was deformed, and then you went across and you went inside the stent and then out of the stent. So you open a strut of the stent. You are not in the true lumen. This explains why you were unable to open completely the stent, and then you had to crash.
Okay, thank you very much for your comments. First of all, I was planning on putting the stent flush to the ostium of the side branch. So that's why at the end in my discussions, I said I should have used the special technique, single string technique, or a wire.
Put a balloon in the main vessel and then pull. It's balloon assisted T-stenting.
Or this, which I didn't think about at that time. And also I was very convinced at this projection that I could place it at the ostium. And then, as usually, the patient kind of inhaled deep, took a deep breath, and I was going back. I mean, that's things that happen, and that's why you should exactly put a balloon there, because that would move together with the patient breathing and it would prevent that from happening. But then I did not realize that it moved proximally, and unfortunately I didn't take a picture or a fluorostor before I came in with the second balloon. So the next image in my presentation shows a second balloon, and that is obvious that you push it or flip it upside down. But interestingly, this was not the case. It was already there before I put this other balloon. I just didn't fluorostore it. So I think it just moved either by itself, or while going out with the balloon, the patient was probably moving again, and the balloon just came back a little bit, and it just needs a little bit force, and that it flipped over. So this is what happened.
You say a little bit of force. I mean, it's an impressive articulation for it to.
Yes, and it also shows me how far it went into the main branch.
Yeah,
this is a little bit disappointing. So, yeah.
So you highlight that your initial intention was to maybe try and rewire through the lumen of that stent, the articulated stent.
Yes, and as Remo Albiero says, I probably came through one of the struts and then got into the true lumen, and that's why I could not fully expand the stent. However, when you look at the 40 NC balloon being constrained by the stent, if I would go through just one strut, I would expect like a narrower neck, and it's actually quite a long neck, which is almost as long as the protruded segment. So I was a little bit hesitating if that 2.5 synergy actually expands to 40.
I mean, you show the Foyne data nicely in terms of the overexpansion capacity of the device, but I mean, I wonder whether the constraint is vessel rather than necessarily stent, or a combination of the two. Because to my eye, 4.0 seems quite big for that distal LAD territory. It would be interesting. So I think the constraint is probably a combination of both the unique nature of the device deformation and the vessel.
And also, I mean, Remo is right, because I was at least going through one side hole, because that's where the stent was flipped over.
Yeah.
Entry there is a side hole, and the exit is actually the true lumen of the stent. So at least at the entry point, you cannot overexpand that stent to 40. And then I decided to go sideways and do the crush, which I should have done in the first place. Yeah. In the first place, I think I should not have stented it at all. Just do a drug-coated balloon. Then if stenting, do the balloon-assisted stenting and leave everything out.
Yeah.
Sometimes you get an inverted provisional. You go in the, when you have this 001 and inverted, you go proximally in tension, proximally, and then you do your pot in the LED, and then you do your kissing. Sometimes the LED, if there is no disease distal to the diagonal, you can have a good, we call inverted provisional.
Yeah.
For a big diagonal, sometimes it depends on the vessel size. If you have the balloons too, but if the distal main vessel is not so big, very similar to the diagonal, you can do an inverted provisional.
Also, there was a big LAD. At one point I was even thinking about snaring it out into a guideliner and then just leave it. But this is how I came out with the case.
Yeah, I mean, the snaring has its own dangers. You're clearly going to result in some form of vessel trauma in retrieving from so distal in the vessel. I mean, we haven't touched upon the deformation of the megatron that was achieved in your attempts to overcome the distal vessel complication. So, I mean, it's a really nice demonstration of how one complication often leads to multiple complications due to the very stressful nature of these situations, I think. But they're two great cases, but they both seem to highlight that hindsight's a wonderful thing. The regret of getting to where you got to, where it could have been avoided, I guess, is always the reality of these things. Good cases.
Absolutely agree.
Thank you for your contribution.
Thank you for sharing your case in such a humble way, really, because they're dreadful complications. But the first case doing it on a mobile C-arm, I can only imagine the complexity of working in an environment like that.
Yeah.
So you mentioned about, you know, your failings of not undertaking a pot or kissing into that left main stent on the original intervention, and yet you passed a device, you passed a balloon, you passed a stent. But really, thank you for sharing it with such humility, because they are horrible complications, and I think, you know, the experience of that is not a pleasant one. And then to encounter a second complication on the next procedure, it's not Dumb and Dumber, it's unlucky and unluckier, I think, would be my take on it. I mean, I was impressed by the fact you delivered equipment through the previously deployed left main stent without any obvious restriction. You know, once you'd entrapped the stent on the way back out of the left main, you say that, you know, deploying it was your best option. It was a 2.5 stent, is that right? And the left main was 4.5?
4.5.
So realistically, you're having to very significantly overexpand that stent in the left main. Was there an opportunity to consider a snare, to actually just try and snare the proximal end of the stent and retrieve it?
After the stent was trapped in the struts in the left main, I tried to push it down by the balloon. Yeah. You know, and my idea is to go down and deploy it in a vessel wherever, not in a lesion.
Yeah.
It couldn't go down, and then I decided not to try any technique with a balloon or with a snare or with a, let's say, more wires to catch the stent, because I was afraid that I will pull the old stent and deform all the stent in left main and have the catastrophe, you know. And then decided just to, I was aware of a mismatch, but of the stent in the vessel, but I think that was the only option at that time.
Sure. I mean, to refer it then on to a center that has imaging capability seems like exactly the right thing to do. Did you get any feedback or any images from them in terms of how things looked?
Yes, I called, and they told me that everything was okay, because there's only one strut after the ostium of Cirque that they have the troubles, because you know, I was not aware what's going on, because the balloons wouldn't go after the angulation of the ostium of Cirque. Nothing was going down. And I have a lot of troubles to deliver the bigger and bigger balloons. And they have the same trouble, but they see that there is a strut. When they compress it with a non-compliant balloon, everything was going easy. And on OCT, the expansion of the stent was very good, and was very easy to, of course, to do the final kissing to the left main, to the LAD, and to finish the procedure.
Not because there was a contribution of the ostium of the Cirque, but I think that it was the edge of the guiding catheter that, you know, you went against the edge and then you slipped everything. So I think based on this that you could be able to recover with a snare, because it was not, it was endothelial, the ostium of the Cirque was not free metal, was endothelium. And probably it was the edge of the guiding catheter that created the slippage from the balloon. So just go with the snare, and probably if you to crash the stent was a better idea. I think crash completely and then cross with another stent, do a culotte, just gel everything. This was probably the best solution. So when you have a stent that you can retrieve, try. If you are unable to retrieve, cross with another guide wire and stent in a culotte, and you know, gel the stent is in the left main is acceptable.
I was afraid that after I couldn't push the stent down, stent new balloon in the stent with 2 atmospheres, 3 atmospheres in the stent, I was afraid to pull it out. I was thinking about everything. And for crushing the stent, I was afraid that 2 metal too many metal in a left main, because there is a viability of anterior wall and small right coronary. I was not trying to lose the LD.
Yeah, but when you crash, you have to go with a balloon to the kissing and then put a stent over the crash stent. So you have to convert in a late culotte, something like that. Left main circuit, and then you were sure that everything was okay.
I mean, the most important element in that decision is understanding how large you can safely expand the device you've lost.
Yeah.
Because you know, it being a small vessel stent platform, you're very lucky to get it up to 4.5, because most of the platforms won't overexpand to that capacity. And so if the left main had been bigger, or if there had been concerns that the stent couldn't expand, then I think, as Remo says, you either have to crush it into the wall or try and retrieve it, which is going to be a horribly physical process. I mean, regardless of whether it's catching on the guide catheter or on the struts that are crossing the circumflex ostium, there's a kind of fishhook interaction between the stents, and so the physical withdrawal of that stent is going to disrupt the left main. So you're committed then to having to re-establish the left main optimally, deal with the distal circumflex, and pick up everything from there. But I think the lesson has to be that you only deploy that stent in situ if you're confident that it's going to match the size of the left main. So I mean, it's good to hear that that's what you've achieved, but it was lucky, is my feeling.
And the other comment is that I always finish with the balloon in every bifurcation. There is the LED diagonal, circ marginal, but in left main circ always I finish with the, because this is very important. This case underlined the necessity to open the stratum, the circ, for the future, because you don't know, you were the operator, but maybe you forgot that you did this patient. So if you have a patient in your cath lab and you don't know if they open or not the stratum of the stent, first of all, if you are the first operator, open. This is the lesson, in my opinion. And you were unlucky because the balloon crossed very easily. So you forgot that there was some restriction to the entrance. So, but it's something that you have to think about for the future. And I had one similar case many years ago with the cutting balloon. It was an extended stenosis, so the cutting balloon broken, so I had to send the patient to the surgeon because the cutting balloon was trapped against the main vessel stent. I was unable, and I was afraid, so I sent the patient to the surgeon, and the surgeon removed the cutting balloon with it was very hard. He had to open and to evaginate everything to be able to cut the cutting balloon. So every device that you go in the circ is dangerous.
But thank you for sharing the case with us. It offered up a whole lot of opportunity to consider the approach. It was great. Thank you.
Thank you.
Thank you.